Good afternoon, everybody, and welcome to Power Hour. I'm Franklin Walker with the North Carolina Medical Society, and we have several guests today to talk about telemedicine. We began Power Hour last April, and our first Power Hour was about telemedicine, and a lot has happened since then. Our guests today are Dr. Steve North, a family medicine physician and also the CMO of Eleanor Health. Dr. Ken Dunham, who's a psychiatrist in private practice and is the behavioral health CMO for Carolina Complete Health. And Dr. Kathy Wibberly, who's the director of the Mid-Atlantic Telehealth Resource Center. And so before we get started, I want to give each one of the guests to just tell us a little bit about their entity. And Dr. North, let's start with you, please, sir.
Sure. So my day job is with Eleanor Health, where I am not the chief medical officer. I'm the vice president of medical operations and state medical director for North Carolina. Eleanor Health is a multidisciplinary substance use disorder program that treats folks across the state and actually across the country. And right now, about 95% of our patients are seen via telehealth. I've got a wide variety of experiences over the past 15 years working in telehealth.
Super. Kathy, how about you?
Yeah, I am director of the Mid-Atlantic Telehealth Resource Center. So we are one of 14 resource centers federally funded by HRSA to provide technical assistance, training, and basically soup to nuts consultation services for entities. Our focus is mostly on rural, underserved, and underserved populations, but we basically work with anyone. So we have been working with large health systems, small health systems, hospitals, private providers, you name it, across the landscape of physical health as well as mental health and dental health and all of those pieces. We are physically based at the University of Virginia, but with my resource center hat, I am not representing the University of Virginia when I am doing my consultation services. And we basically are set up with a group of a network of consultative service partners also, so that we go from very simple questions all the way to much deeper dive kind of program setup, workflow, you name it, types of assistance.
Super. Dr. Dunham, tell us a little bit about your entities that you're involved with, please, sir.
Sure. Hey, everybody. I'm Ken Dunham. I'm a psychiatrist and internal medicine doc. Been practicing in North Carolina since coming out of residency. Working with Carolina Complete Health, which is a Medicaid managed care prepaid health plan in North Carolina, who's enrolling members now. This kickstarted in July. One of our partners is the North Carolina Medical Society, so they are a parent entity of Carolina Complete Health. I'm behavioral health medical director there. Working with Carolina Complete Health, they require me actually to continue in private practice. This is a insurance company that says, hey, if you want to work for us, that's great, but you still have to keep your pulse on what's going out there in the real world. So I do have a day clinic, a private practice clinic in Winston-Salem, North Carolina. And I'm proud to say I'm a KIPL alumni.
Super. Thank you, everybody. Okay. As I mentioned, we started Power Hour last April because of COVID, actually. And due to COVID-19, telehealth is now a necessity rather than a complementary service to operate business around the healthcare spectrum. So things have really changed in the last year for telehealth in the telehealth industry. So my first question to the panel is, how has the public health emergency, which is COVID-19, changed the landscape of telehealth? So Kathy, can I start with you, please?
Yeah, I think the biggest change is at the policy level, but because of the policy level changes, it has changed the whole expectation and status quo of providers as well as consumers. And so I think a couple of big policy changes obviously were related to reimbursement, removing for Medicare, removing geographic and site restrictions, expanding the group of eligible services, allowing use of audio only for some services, easing some of the HIPAA requirements and Stark and anti-kickback, and So I think those are things that really made a big difference in the landscape of telehealth.
Super. Steve, I want to come to you and give you a chance to add on to what Kathy said a little bit. And I know you authored an article recently, which you were kind enough to send to me. And maybe some of what Kathy said can be linked into your article that you might want to highlight for our guests.
Yeah, sure. So the article, the draft was just sent into Family Practice Management. It won't come out for a couple of months, but I think that the biggest change we've seen is provider comfort with telehealth in general. And so that small providers outside of big health entities or academic centers are now comfortable, or at least somewhat more comfortable, integrating it into their practices. And because of several regulatory changes, one being the HIPAA, the enforcement of HIPAA around security of the telehealth platform, the ability to use FaceTime or Zoom without a business associates agreement has been a great boon for our primary care docs. And I think one of the challenges we see now moving forward is how do we move from actually using telehealth as a stopgap measure into incorporating it into our practices as a new way to provide care? And how do you balance that out? How do you take a patient with type 2 diabetes and instead of saying, I need to see you in the office every 3 months, move to saying, let's have more frequent, shorter visits, check in on diet and exercise, check in on your blood pressure when you use a home monitor, but really only see you in person every 6 months for your foot exam. How do we do that? So that's really where one of the big challenges is moving forward.
Super. Ken, anything you want to add to what Kathy and Steve mentioned?
Yeah, I think one of the biggest things that we've come across, in my opinion, is those patients who need scheduled medications, Schedule 2, Schedule 3 medications, ADHD meds, opioid use disorder meds, Suboxone and Suboxone-like medications, especially, and how that has kind of helped access for that population to stay stable in the community during this time. I think that's one of the biggest benefits of this. And at the same time, it just kind of a makes sense benefit as well, thinking about all the people with substance use disorders who don't have adequate transportation. How can we continue to serve that population, keep them out of the hospital, keep them healthy during this emergency era as well as after.
Ken, I can't agree more. Eleanor has really transformed what we're able to do because of the pandemic. And we've actually continued to grow we've increased our patient panel by about 300% in the last year, which actually exceeded some of our growth expectations with just bricks and mortar practices because we can expand the reach. And it's a concern, what happens if the Ryan-Haidt Act, the policy that from the DEA that allows, that restricted the prescription of stimulant medications and other controlled substances without seeing the person in person one time, what happens if that suspension, if it is stopped, if it's reinstated to all these folks who have entered care virtually and are receiving high quality care, who now need to be seen in person or had their care transferred? And it's something that I'm watching pretty closely.
Right, that's a great point for both of you. One thing that I want to get into, and Kathy, you had mentioned in your work with your TRCs, you're targeting a lot of these rural and underserved places. Ken has just mentioned issues with transportation, okay? And I know where Steve practices in an area in Western North Carolina that's a very underserved area. And at the Medical Society, we now are focusing on health equity in a lot of our mission statement driven work, okay? So I want to get into how do we address health disparities and health equity with telehealth when you have patients who do not have access to broadband or video-enabled devices. And Kathy, I'm going to come back to you on this first from a policy perspective, and then I'm going to come back to the clinicians and talk about on the ground and how you're doing it and how you're overcoming it, and maybe some of your ideas about how to overcome it. We do know that we've got the Last Mile Initiative in North Carolina, which is trying to push broadband out to rural and underserved areas. So Kathy, let's start with you. Can you please address that, health equity and health disparities from a policy perspective, and maybe what you see coming down the pipeline for the TRCs?
Yeah, absolutely. So I think a couple of things that the public health emergency really brought to the forefront of everyone's attention is this disparity in broadband access. And it's not just health, but education as well. We've seen as, people have gone to hybrid or virtual school that, students are being completely left out if they don't have broadband access. And so we are definitely seeing a lot of money come down to try to address this issue. And the FCC just authorized the emergency fund for consumers to actually be able to get reimbursed for their broadband access. And we should be hearing more about that in the next couple of weeks, or much more about that in the next couple of weeks in terms of the guidelines for how you access those funds. But I think, in light of all of that, we definitely need to take advantage of that. So, any opportunities that you can, as a provider, really advocate for your patients and clients in terms of the broadband access. This is the time to do it because there is funding right now available. But I think we also need to be creative. And we have seen a lot of creativity in the last couple months in terms of how we get people access. So some of the larger entities are actually providing, for people who don't have devices, providing devices to people so that they are Wi-Fi or broadband enabled devices. We are seeing some nonprofits crop up that are trying to address this issue. There's one that's called I think it's Telehealth Access for Seniors, and they're basically started by a group of Yale students and are now in about 30 states that provide both digital literacy, technical assistance, refurbished devices for people who don't have it, as well as provide very easy to understand kind of guides and manuals, tech guides for people. They're called Telehealth for Seniors, but they're really focused on the equity issue and for patients who are, or they're working with providers who are working with patients with very low access to funds and resources. So that's definitely, and we're seeing more and more of these nonprofits come up. But I think in terms of the creativity piece, we're also seeing a lot of communities be more creative in how to do that. So they're creating access points, whether it's through libraries and schools that have been closed. We've seen some kind of Main Street initiatives where abandoned storefronts in rural areas where they've had, been basically just unused for a while. They've kind of reopened them up, installed some access points in those areas. So I think there's definitely room for more creativity in that area in terms of building out the infrastructure to make sure that patients have access to some level of broadband.
Super. Steve, I want to give you the next shot at this. And again, let's think about health equity, health disparities, and in your practice, how are you guys addressing that and your thoughts around that?
So we have not moved to the point of being able to provide a device to folks or facilitate broadband at their home. We have in some situations taken one of our community recovery partners or nurses, and they have gone to the home with a device and a mobile hotspot to conduct the visit. The other thing, I live in Mitchell County, so northwestern North Carolina, next county over from Mount Mitchell. And there's a little community way up almost to the Tennessee line called Beulah Dean. The community center there has had Wi-Fi, but they used to shut it off at night and when people weren't in the building. And so I help lead another entity called the Center for Rural Health Innovation that does rural school-based telemedicine and some other community engagement projects. And we work to get that left on all the time. The cost is the same for them. And now through Eleanor, we're having patients who go to the parking lot there to be seen in this little community because they don't, the last mile broadband project hasn't made it up their road yet in Mitchell County.
Interesting. Ken, coming to you on health equity and disparities.
Yeah, too. I'd like to answer this with kind of two perspectives, one from private practice clinic and one from Carolina Complete Health. So my private practice clinic, I have that we do offer psychiatry, and there is a significant difference in the under and uninsured people that we're serving at that clinic and their access to kind of the phone and the quality of the telehealth conferencing. Even some of our insured folks, when they work in the rural areas, the quality of the connections are not so good, and sometimes we have to reboot more often than not, or end up calling them on the phone. So it becomes less of an efficient process and kind of a hindrance to care. So any type of push to get technology to the hands of our folks in the rural area who are underinsured is going to be useful. From the Carolina Complete Health standpoint, I think that's where the value added benefits of the future Medicaid and managed care companies that they're in North Carolina now come into play. So, for example, some of our members will qualify for a cell phone with free calls and minutes as part of signing up as a benefit to the program, and that's to help in part solve these type of problems that are coming up under traditional Medicaid and how traditional Medicaid works. You're not able to do that, but this type of waivered environment where Medicaid companies can be more innovative, those are some things we're allowed to do. And so I don't know if it's it'd be great if providers could hand that technology to folks, but it appears like the push is coming through payers and nonprofits and other programs to get that type of technology to folks. I do also want to say that Peter Bird has joined us from Carolina Complete Health, and I just want to take a time and introduce him as well.
Thanks, Dr. Dunham. Good to see you all. That's very gracious of you. Yeah, I'm Pete. I work with Dr. Dunham, and I work for Dr. Rachel Keever over at Carolina Complete Health Network, heading up strategy and performance. So highly interested in what y'all are saying. Thank you.
Super. Hello, Pete.
Hey, Franklin. I think we need to remember that telehealth isn't about rural anymore, and equity issues and access don't just apply to rural. Right. You can live in inner city Durham, and because of your socioeconomic status, not have the money to have the access that you need. There's also the issue of health literacy and technology literacy that needs to be considered. So as we talk equity in virtual care, we really need to push that conversation away from just being a rural issue, which has been promoted by sort of old school CMS regulations, having kept Medicare reimbursement restricted to rural communities, and now think of it as one of the great tools we can use to bring care to people where they wouldn't otherwise be able to receive that care, whether it be primary care services or specialty care.
Yeah, I was about to echo what Steve was saying. And having worked in the State Office of Rural Health and Primary Care Office, and we saw some huge disparities in even urban areas where if you don't have access to a car, you could literally be 5 miles away and be on a 1-hour bus route because you have to change buses 6 times to get there. And that, that is a barrier, a transportation barrier that is an urban barrier to getting care.
Yeah, Steve and Kathy, I couldn't agree with you more. In some of the work that we're doing through the Medical Society Foundation has looked at, rural underserved historically, and in the last 10 years has kind of looked at that, what I call rural or urban underserved, which Steve, you had mentioned. Kathy, you had talked earlier about some policy changes that you all had looked at. I'm wondering if you've seen things from a policy lens that have changed because of COVID, et cetera, that you're going to recommend from your standpoint that should be permanent. Can you speak to that?
Yeah, so I think there are a number of things. One, particularly from the CMS perspective, the geographic restrictions, we were just talking about that. There's no reason to limit reimbursement for telehealth to rural. Because we have urban and suburban underserved as well. And we have populations, senior populations who cannot get out and about, people who are disabled and have other issues. And so, why limit it to rural, first of all? I think another thing that we're seeing is the audio only piece. because we are in a place where we can't have broadband everywhere. At some point when broadband is ubiquitous, we could probably remove reimbursement for audio only. But I think at this point, there are some patients that will not have access to anything if you can't reimburse providers for audio only. So I think that has been a challenge, and it's been a debate. I think even from state Medicaid programs, people don't want to call it telemedicine, but they also want to make sure that providers can get reimbursed if audio only is the only option. So I think that is kind of a little bit of a tug of war at the moment, but providers definitely need some way to get reimbursed for their time if they're going to be spending an hour on the phone with a patient, because that's the only way that they can be seen.
Agree. Steve, I'm wondering if you can speak to what Kathy talked a little bit about and maybe a little local flavor from a state level, what your recommendations might be.
Yeah, so having done, my prior life, I was at Rural Health Center up until October, and having done audio only visits with established patients, it's a really good conversation. You actually have a little bit more time perhaps than in the exam room to explore some of the things you miss out on. Partially because they just want to say, "Oh, I'm good, doc," and hang up the phone. But the other part is that you actually are able to look at the EHR a little bit more and ask about all the medications and talk about health maintenance in a different way. Moving forward, I feel that there's a clear role for audio visits, but I think that it needs to be in combination with some expectation of a future in-person visit. And that in-person, by in-person, I mean video or in the office itself. And it may be condition driven. I think that for behavioral health, audio only can be great. If I'm trying to manage heart murmur and congestive heart failure, I need the weight at least. I need to look at the edema, listen to the heart. So how do we balance this in protocols? Do we need to go to that extent, or do we say the recommendation is, or strongly encourage, a blended use of audio visits with future video visits? Then there's also the question in the policy side about, can you initiate a visit and establish a new doctor-patient relationship with audio only? Right now, I think that it's better than no access whatsoever, and that's really important. Long term, I think we need to have a good look at that as well and see what the outcomes are for folks who have had audio only care versus video care versus a blend of all three modalities.
Right. There's a lot of questions out there about what types of patient visits are appropriate for telehealth. Steve, you kind of hit kind of around there. And I'm wondering, there's going to be a certain amount of patients, I think, that are probably going to be very reluctant to return to your waiting room, to Ken's waiting room after COVID's over. What are you thinking is going to be a strategy for getting those reluctant folks back in your waiting room, knowing that you do need to lay eyes and hands on them face to face? What are you going to do about that?
I think it's about the conversation you have, and it's about the health maintenance things that I can't do when you're not in my practice, or I need to think creatively about ways to achieve those things, whether it be a hemoglobin A1C or a urine drug screen, outside of sort of the normal path that you have to come into the office for this. So also making sure that as a medical provider, I feel comfortable with the exam that I'm doing without the benefit of a stethoscope. Maybe we do need to look towards more sort of packages being sent to people with some virtual care equipment, or sending out, there's some programs around the country where a technician goes out in a car and with the telehealth equipment. There are two large companies doing this to facilitate the visit to a physician who's located wherever. And that is a model to explore. So the home health aide takes the technology to the home for that every 6-month visit and performs it under the direct supervision of a doc. So we need to be creative about how we do this and use it.
Yeah, yeah. Ken, same kind of question to you from your perspective. How do you overcome reluctance getting folks back to being in person in your practice?
Sure. So I think if we can keep them out of the practice, that's the goal. If we can get quality endpoints, good care, and they don't have to just come to the clinic, that's what we should be going for. I remember back, I did my training at ECU, and back in the 90s, Telemedicine Center at ECU was working with Air Force and NASA, and we had digital stethoscopes out in the field and doing telemedicine and derm cams. Now all that stuff is in small packages, and people are willing. They're more tech savvy. There's community people we could get to kind of train folks to do exams in the community. Now, is it going to be the same as coming to your physician? No, but not everybody. Maybe not everybody needs to get there if you can have the same type of outcomes. And I think we could all benefit in those shared cost savings. So I think this is helping us. And these ideas have been around for decades, right? It's nothing new. It's just a matter of, we had a public health emergency that kind of helped stimulate some changes. And so how can we look at going forward to keep those changes going so that our members of North Carolina have great health, better access to health with as much convenience and access as possible.
Yeah. Ken, I want to stay with you a little bit and talk specifically about behavioral health in the rise of the need for behavioral health because of COVID. And you and I have had some of this discussion in our opioid task force work. And I'm wondering if you can talk a little bit about, one, the increase, the spike in the need for behavioral health. Where has that occurred? And then talk a little bit about how maybe telehealth has been leveraged to kind of take care of that and mitigate that spike a little bit, please.
Sure. So I think behavioral health, psychiatry was positioned at the beginning of the pandemic in a preferred environment anyway. A lot of folks had telemedicine, or if there's telemedicine applications out there, many of them were for therapists and online care, psychiatry. So they kind of had an edge to begin with. So it's an easier transition for a lot of folks. Now, having said that, many people in North Carolina, therapists, psychiatrists, still have paper charts because our group wasn't really required to move over to EMRs, right? So if you take behavioral health as a whole, and so that transition has been difficult. Now, having said that, there are now therapists and psychiatrists in the community who are all 100% telehealth now, and that's all they're doing, and they're talking about maybe not coming back at all to that. In my private practice, we're about 70% face-to-face, 30% telemedicine at this point. We actually have people call us up because we still see people face-to-face, and we of course take the appropriate precautions, but we have people actually come to us because we're the only ones that they can find that are actively seeing people face-to-face, which is something they feel like they want. We're happy to provide it. I think the biggest thing telehealth does is increase access. So people who didn't have access now potentially have access. There's still a bottleneck on total number of providers out there. And so I don't know about volumes, if there's any better. I don't think we have really increased the number of people encounters seeking care in North Carolina based on all the meetings I've been in, but we have definitely increased access, or the ability for people to get care who otherwise wouldn't get care. So there are people who were getting care face-to-face who are not getting care now because they just aren't able to do so.
Yeah.
May I contribute something?
Of course.
Ted Kinsling speaking here. I'm a retired pulmonologist and was formerly chief medical officer at Duke Raleigh Hospital. I'm now the new president of the Wake County Medical Society, trying to decide how to reinvent herself. But I think it's important to remember the why we were getting into telemedicine in North Carolina, it had to do with public health and avoiding the spread of virus. And I think we're learning that telehealth has some good things and it has some issues. And I think we need to really sort out where it works and where it doesn't work. University of Colorado, Dr. Jay Shore has a lot of experience with telehealth on Indian reservations, which are spread over a vast area. And certainly access is important there. On the other hand, if you're in the mountains, having to send a paramedical person up to a small town, is that really telehealth or is that really, some other type of an extender? I went to see the dentist yesterday. I cannot conceive how a dentist could ever function over telehealth. So we need to really kind of sort out what works and what doesn't work. I've been hosting Zoom meetings about 10 or 12 times a month for the past year. There's some things that are really good. We can get speakers from a long way off. We can have participants from a long way off, but we all miss getting together. And when the electronic medical record came in, there are lots of wonderful things about it, but it was also a major factor contributing to physician burnout. So we need to really think about, will telemedicine make medicine even worse for the providers and make burnout worse? So there's a lot of things that we need to really work on with it.
Yeah, Ted, I've been working on telemedicine programs since 2007. And I think that one of the things to think about is the modality that's really being used to deliver the care. So University of Virginia, where Kathy is, has an extensive history of extending the reach of specialty care. A great example is cystic fibrosis. They've got a statewide cystic fibrosis network that uses digital stethoscopes, like Ken mentioned, and uses, local resources to guide that exam so that the knowledge is not limited. And AAP has a recent release, like yesterday, of distances to pediatric subspecialists. And we see huge swaths of the country where 25% or 90% of the kids don't live within 100 miles of a specific pediatric subspecialty. So thinking about how we use telemedicine with peripherals in that setting to spread that expertise is great. The provider experience is also really, really important that you bring up with the EHR. And how do we make it an enjoyable experience? How do I have that relationship with an individual when I can't give them a pat on the back or hug my 92-year-old patient as she leaves the room? That's another important thing to be talking about. How do you do that well? I find virtual visits to be a little bit more demanding because there's some showmanship, at least, of keeping people engaged. Just before this, I was seeing a gentleman in Louisiana and working with him on his opiate use disorder and his ADHD. And how do I keep him engaged during the conversation when he's also at home with kids running around in the background who are doing homeschool?
That's super. Thanks, Ted, for chiming in. That's great. Kathy, I want to come back to you for a second on this. And what do you think the role of telehealth is going to be after the public health emergency? And again, we can debate at some other point when after is or what after looks like. But give me your thoughts from a TRC perspective, a policy perspective, what that is.
I think it comes back to exactly the conversation that just happened right here.
Right,
it's,
right.
Really figuring out. And I think prior to the public health emergency, people were kind of looking at telehealth as this dichotomous thing. You either do telehealth or you don't do telehealth. And now I think what people have really started to learn is telehealth is simply a tool. It's a tool just like a stethoscope is a tool. You don't use a stethoscope for everything, and you're not going to use telehealth for everything, but there is a role for telehealth in probably every practice model. And so, so really I encourage people to look at their workflows, look at their patient population, look at the services, and really take a close look at, how many times are patients coming in when they really don't need to come in? because we are seeing even through the COVID public health emergency that people are missing appointments much less when you're offering those appointments by telehealth. And so, is it better to have to schedule 10 appointments in the office and have them miss 9 of them and show up for one? Or is it better for care overall if, you basically say, we're going to cut out all the unnecessary in-person appointments. They're only going to come in when they absolutely need to come in, and we're going to do all our other visits by telehealth. And some of that is really training the provider to do, how do you do a physical exam by telehealth? I think providers are learning they can do so much more than they thought they could do. And that is one big piece of, this whole puzzle is helping providers understand what they can and can't do and helping them to increase their skills so that much more of that visit can be done virtually.
Yeah.
And I want to jump on what Kathy just said, providers knowing what they can and can't do, because one of the concerns that I've had for years about telehealth is that I see that I can't treat the ingrown toenail virtually. My drone skills are not that good yet. And my response should not be, well, you need to go see, urgent care for this. My response needs to be, this is better treated in urgent care by your primary care doc, and I will make that connection for you. We need to have the continuity of care. And a big concern I have is the siloing of care that happens because of telehealth. I now can, get treatment for a specific issue, whether it be erectile dysfunction or oral contraception. Not me for either of those, actually, but I can get those, but the two never talk and never go back to my medical home. And I think the medical home needs to expand to include the use of telehealth so we can avoid this siloing of services.
Yeah, I agree. We had something, Stephen, I think the family physicians were involved in this many months ago. A corporate group had come in to provide telemedicine services to North Carolina at the urging at the time of one of our commercial insurance companies, which then created chaos where, of course, the patients being seen by a California doctor via telehealth was removing them from that patient-centered environment. And I know we had a real scrum about that early on. And I know, Kathy, I've mentioned that to you guys when we've worked together with your group.
And the doctor in California, no matter how wonderful that individual is, doesn't know the local resources, whether it be a referral food pantry
exactly.
or contacting, mobile crisis.
Right, exactly right. I want to welcome one of our guest panelists today who has just been able to join us, Matt Lestrina, who is the Director of Telehealth with Carolina Complete. Matt, welcome. How are you today?
Very good. Thank you for having me.
Okay. Since you're on, I would like to really get into some questions from a payer perspective. I know we have 3 folks on the call today who are employed by Carolina Complete Health, Dr. Ken Dunham, Pete Bird, who's been a great listener today, and now you're on, Matt. So I want you guys, and maybe Matt, maybe you can take the lead on this, given that we are getting ready to flip the switch on for Medicaid transformation in July and across the state for these new MCOs that are going to take over our Medicaid program, and talk a little bit about what you guys are going to do for your members and for your network of doctors, leveraging telehealth, and really just, putting this thing on hyperdrive going forward. Matt?
Sure. So we have a few initiatives planned for Go Live. The first being a closed loop behavioral health referral platform. This will enable CCH care managers to refer members to BH providers with visibility into appointment completion. We also plan to deploy mobile-based behavioral health self-management tools. The mobile app toolset to empower members to take an active role in managing their health and to improve their overall health outcomes. A third, we plan on delivering our care needs screening through kiosks in major retail stores for our members. We plan on also leveraging text-based member engagement and population health programs, as well as virtual physical health and behavioral health visits.
Super. Ken, did you want to add anything on that from a provider perspective for Carolina Complete?
Yes, a provider perspective is that we're trying to make it real easy for providers in North Carolina. So one of the ideas behind, we're the only provider-led entity as a prepaid health plan for Medicaid. And what does that mean? That means there's a bunch of physicians in the insurance company. So our goal is to try to make it as easy for providers as possible. Try to get rid of bureaucracy when we don't need bureaucracy. So I'll make it easy for patients to get the care that they need. So I think that's the goal for us, and that's probably the only thing I would add to what Matt was saying. Is all these things that were listed are really for to make it easier for both the member and provider to help get the patient the care they need.
Gotcha. Steve, I want to come back to you with a kind of derivative of this question from Eleanor's perspective. I remember when Eleanor started, and there was the bricks and mortar that you mentioned, and then here comes COVID. Patient panel ramps up by 300%. You guys were started, I think, initially based on commercial, but it was always my understanding you wanted to move into the Medicaid space, the underserved space. Mm-hmm. So my question would be, as Medicaid transformation starts in July, what are you all doing in Eleanor to leverage telehealth? Because you were started under another business model. You were bricks and mortar over here, and now you've got this great, fulcrum of telehealth. What's going to be your strategy going forward for Medicaid transformation?
In 3 minutes or less? That's an easy question, frankly.
So, it's a great question.
I think that the access issue is going to be interesting to look at, because there are now 5 Medicaid managed care plans, and we are enrolled with all of them. But there's the differentiator between the managed Medicare plans and Medicaid plans, and when does someone step into one of the tailored plans for behavioral health? Because that's another set of entities where we need to be credentialed and enrolled. And while Ken probably thinks that I'm a nice guy, I am a family doc and an adolescent medicine specialist, and maybe his plan feels that addiction medicine care shouldn't be provided by me, but another group does. How do we keep track of all of that as we move across the state and continue to grow? And that's actually not a comment about Carolina Complete Health. They've been great to work with. So Rachel and William are good folks. So I think that Eleanor is looking at Medicaid transformation as a way to continue to expand the access we provide to patients with Medicaid and the uninsured by having more payer support virtual care. It's going to increase innovation. It's going to increase utilization, because if we step away from Eleanor and say that I'm a solo doc and only Carolina Complete Health is the only Medicaid provider who will reimburse me for a virtual visit, and 1 in 5 of my Medicaid patients has Carolina Complete Health, I may not invest as much in the effort to build a telehealth workflow and do the sort of operational changes that need to happen, because this is not just about a piece of technology. Stepping back to our Eleanor model, what we are focused on is building a value-based care solution to substance use disorders. So we have 2 value-based care contracts with large health insurance companies now, and hope to negotiate those with others. Because when we move from being paid the piecemeal by the visit care to value-based care, we are able to use virtual care in a whole new array of ways. And we can use digital therapeutics. Matt brought up their suite of behavioral health apps. And so Eleanor is building our own behavioral health app and looking at certification of that in a variety of ways to be able to deliver asynchronous care. And so how do you do virtual check-ins and have somebody just rate their substance cravings or their depression or whatever other score you want every day, just like an app like Noom does for weight loss. Sorry, speaking of virtual learning, you may be hearing my 12-year-old run up the stairs at lunchtime. Yeah, but that's what, how do we take this innovation that's occurring in the private sector space, whether it be Headspace or Noom or any other place where you check in on a daily basis, and bring that into the health sphere where it's actually integrated into the care I provide as a medical provider.
Right. Super. My next question is for the CCH folks. And Pete Bird, I may even get you to chime in on this. As you all have built a network for CCH in North Carolina, particularly in regions 3, 4, and 5, certainly there's some providers that have been reluctant to jump on and do telehealth, even as cool as some of the stuff that Matt outlined, right? And Ken's a proponent of this. He's using it in his work. What are the strategies? What are some of the things that you guys are employing in your network build to get those providers up and running on telehealth, on a platform? Talk about some of those strategies. And Ken, you can go first, please, sir.
Sure. So I think the biggest strategy is trying to deal with fees and fee schedules and payment, right? So right now in the emergency environment, basically with anybody receiving Medicare funds, Medicaid funds, is told, hey, if you're a payer, you need to reimburse for these things. So that part is easy. I think the trying to figure out, let's say after the emergency is called off, where does that leave people? Or does it, telemedicine used to be a carve out, for many folks and many payers. And so leading the organization to continue telemedicine as a viable form of payment for parity is, I'm a believer of that, and that's what I'll be working on my end.
Okay. Matt, how about you?
I was going to say, I'm going to rely on Pete's team.
Okay.
Well, I will chime in that there are a lot of open questions around this, and that's one of the things that we hope to explore as the provider-led entity in this space. Physicians and other clinicians have a lot of say in the medical policies that we're going to be pursuing, and administrative policies as well. So we're after better health at lower cost, like everybody on the call is. So that if we can find ways to integrate telehealth and other extender type services into the network, we're all for it. And we're also, for those of you who know Dr. Kiever, we're big on innovation and pilots, and let's try some things that have promise and scale quickly the things that fulfill on those promises.
Right. Kathy, I want to come back to you and talk about the future of TRC. And again, it just, I've known you for several years, I've known about your work with TRC and TRC. And as bad as COVID has been, it certainly then has put the spotlight on telehealth, and by default, TRC, elevating you guys up to a whole different level, it seems to me. So what are you guys thinking as the CEO, basically the director of a TRC? Gosh, we've got the spotlight now. We're going to move this thing forward. What are you thinking about? What is your team thinking about moving forward from a TRC perspective to keep you guys up there and keep you at another level of relevance?
I think the biggest thing that happened with us was the demand. And during those 2 or 3 months when COVID started, we literally had an 800% increase in technical assistance requests. It was insane.
Yeah.
But I think what we have discovered is that we need to do much more in terms of curriculum development. And I think if you had asked me this question 3 years ago, I'd been like, yeah, we tried reaching out to the health professions education schools and they just weren't interested. You know, the line was, well, there are so many requirements already, we just can't add one more thing. Now I have people knocking at my door, you know, graduate counseling programs, graduate other programs, basically saying, hey, can you do a curriculum for me? Can you do training for my students? And so I think, you know, that's going to be one focus area that I will be working on, is working with a lot of these graduate programs and health professions education programs to really get their students up to speed on telehealth and being able to do it as they, you know, get their licenses and start their own practices. I think another area is doing the best practices training. And I think, you know, we saw very quickly providers pivot to things. And so workflow was one thing that suffered. You know, providers basically said, oh, I'm going to work from home. And then all of a sudden they realized they are like in isolation at home, doing the scheduling themselves, doing everything, and not integrating the rest of their staff. And so a lot of our requests right now are like, how do we deal with workflow when everyone's working from home, you know, or when half our staff are at the office and half of them are working from home. And so really trying to put together some toolkits and training around that.
Super. Yeah. Well, I will say 800%, but when you add that to Steve's 300, that's a lot of increase. That's pretty impressive. We do have a question in the chat, and it says it's addressed to everyone. I'm going to read it. How do you address credentialing and licensing out-of-state providers? I'm going to let Steve take that first, because Steve, in your draft, your draft document that you sent me, you actually talk about some licensure compacts. So I'm going to let you talk a little bit about that, and then heads up, I'm coming to Carolina Complete Health next. Go ahead, Steve.
So this is a great question, because you want to make sure that the quality of care being provided by an out-of-state provider is equal to what someone would receive in state. And there are great physicians everywhere in the country, and there are a few not so great physicians.
Yeah.
In North Carolina, you need to have a North Carolina license to practice medicine. However, 27 states in the country are part of what's called an interstate licensure compact. And it means that if I hold a license in the state of Washington, for example, there are 26 other states that accept that license and have it varies somewhat, but have a smoother entry pathway to having my license recognized in their state. I don't need to go through the gigantic packet that I have recently tried to go through for some other states for telehealth. So that is important. And then credentialing with insurers is interesting. As Eleanor's grown, and in my role as VP of operations, there are some states some insurance plans that will not credential me despite having a license in the state of Washington, because I am not a resident of the state of Washington. And so they're providing some regulation of who can serve folks in that community. And probably that's okay in specialties where there are a whole bunch of people. But if you are the only pediatric nephrologist, you know, potentially serving Alaska via telehealth, and an insurer won't enroll you because you don't live there, that's a barrier to care.
Yeah, sure is. Thanks, Steve. So same question about out-of-state licensure to CCH folks. Ken?
Yeah, so everything has to go through the North Carolina Medical Board, of course. And so if you get your regular licensure through that, you then have to apply through regular Medicaid. We are a Medicaid managed care company, but the way it works in North Carolina is that we aren't directly credentialing providers right now. First, you have to be credentialed through regular North Carolina Medicaid. And then after you go through that process, at least for the first few years, part of the kind of deal between the state and the managed care companies, where anybody that we credential, you have to take. And there's actually legislation that says that anybody who wants to be part of a network for the standard plans, PHP plans, that we are an open network, that any willing provider, as long as they meet the state's quality metrics, that we need to bring in.
Yeah.
And so for the time being, like, I don't see us doing something like the Washington Insurance Company that Dr. North just talked about doing. Is that something possible that could happen in the future? I guess it's in the realm of possibility but right now everything's kind of out of the payer's hands as far as where we sit. I don't know, Pete, if you got anything else related to that.
Nothing to add, Dr. Dunham. Thank you.
Okay. Okay, we're getting close to the top of the hour. So we got time probably for one more question. I want to tee it up. One of the things that we've been working through with North Carolina Medical Society is a telehealth directory. And Kathy knows this. We've been working on this together. The TRCs had one of these things years ago, and Steve, you probably know this, and the data wasn't kept fresh, and we were in a different place. And so our plan is now, as we've started this telehealth directory, where Dr. North's name would be listed, and it would also give the practice information and how that patient could get online and schedule a telehealth visit versus an in-person visit. This would be published. We talked about access. This helps with access. It also helps to rebuild what we're seeing in North Carolina and nationally is a certain percentage, 10, 20, 30, 40% of a physician's book of business has gone away due to COVID. And we believe that you can build that back up, that business back up and the revenue stream back up by leveraging telehealth, particularly where there's payment parity, okay? And I'm telling you guys that we're working on this program. Kathy knows it. It's one of our wish list things for telehealth, for telemedicine. So my question to you guys is, one, what do you think about a telehealth directory? Two, what would be on your wish list going forward for telemedicine? So Kathy, start with you, please.
I think the directory idea is a good one. Keeping it fresh, I think, is going to be the biggest challenge because people change their hours and their times and their services pretty much on a regular basis. So I think, if you can figure out a way to address that challenge, it will definitely be of use. I think as people's models of telehealth change, there was a time when almost everything was hub and spoke model and people were just, contracting and not doing the direct to consumer. And so the directory was not as much of a utility to the individual provider because, it would be like, I don't want a patient to call me directly, just, figure out a contract with my organization. Whereas now we're at a point where people are saying, oh, I can take patients and they can contact me directly and we can establish a new patient that way. So I think, we're definitely in a new time and a directory is certainly one step toward that. To answer your question, your second part of the question, which was about the future, is that what you said?
Your one wish list.
My one wish list.
Yeah,
I think my one wish list is for providers to actually be trained in how to use apps and wearables and just kind of all the devices that would allow them to get information without having to have that patient literally sitting in their office.
Super, super. Steve, I'm coming to you, and you mentioned your drone skills were lacking, so that's not going to be on your wish list because Kathy was just talking about apps. But your thoughts, quick thoughts on the telehealth directory and your one item for your wish list, please, sir.
I think the telehealth directory would be great. Same kind of challenges as Kathy brings up. And then my wish list would be that health insurance companies, instead of providing a number on the back of my insurance card to get care via telemedicine, actually support my local family doctor and his ability to provide that care. Because I'm really focused on how we bring all the care back to the medical home in one way or another.
Right, that's super. Ken, what about you?
Well, the only thing I could think of as a kind of a close competitor in the behavioral health world would be Psychology Today. PsychologyToday.com has somehow taken over the psychiatry therapists, find a provider list in America. They're very popular. And on that, it lists, who we are, where we are. Do we take telehealth? Yes, no. What insurances do we take? And what are our areas, certain number of areas of specialization. So it allows the the patient or the potential patient to look it up, kind of say, I'm looking for a white male therapist who specializes in Christian-based counseling, or I'm looking for a queer-friendly, Asian therapist to talk about, this or that, or I have binge eating disorder. I need a psychiatrist that helps with that. And it seems to be pretty good in that respect and pretty user-friendly. And so I think the user-friendly function of that platform, I would want that as part of, the North Carolina telemedicine search engine.
Yeah. Okay. Well, it's 1 o'clock. I want to be respectful of everybody's time. First of all, I want to thank my guest panelists, and my guest panelists extended to CCH and their 3 folks, Steve North from Western North Carolina, Kathy from Virginia, and all of our listeners today for a very robust conversation. We'll be reconvening after Easter for our next Power Hour. So I hope you all have a great weekend, and we'll see you in a few weeks. Thanks, everybody.